called The Future is Now, Innovations in Outpatient Care, Telehealth, and Everything in Between. Thank you for joining this workshop. My name is Kate Barnico. I'm the CF Center Nursing Program Coordinator at Boston Children's Hospital. My co-moderator is Dina Kempel, who is the nurse coordinator for the CF adult team at the University of Kansas. March 2020 brought all semblance of normal outpatient care to a screeching halt, demanding an immediate change in the way we interact with patients. We were suddenly thrust into a new era of telehealth, Zoom, home spirometry, mask mandates, social distancing, lockdowns, work from home, and COVID 24/7. Instantly, we became telehealth Zoom experts, learning how to work more efficiently from home while trying to navigate the new pandemic world for ourselves and for our families. This workshop features speakers who have done some amazing work, innovating outpatient care, sharing tools and methods that were employed to sustain patient care during COVID and far beyond. We welcome your participation, and so please use the Slido to the right of your screen to ask questions, and we will do our best to respond. I'm going to move right into the session of our first speaker, who is Juliana Bailey. Juliana is a registered dietitian and quality improvement coordinator for the UAB Adult CF Center. She is also a member of the CF Learning Network leadership team. Her talk today is entitled Rapid Pivot to Telehealth and Experience of Care. Thank you, Juliana.
Hi, everyone. My name is Juliana Bailey, and I am the Registered Dietitian and Quality Improvement Coordinator for the University of Alabama at Birmingham Adult CF Program. And I am here today to talk to you about the Rapid Pivot to Telehealth and Patient and Family Experience of Care surveys that we did. So I have no disclosures. And most of us are familiar with how we had to make this quick shift to telehealth in the setting of the COVID-19 pandemic. And we really had a challenge presented to us of providing high quality interdisciplinary care in this new telehealth model where many of our team members were split up because of social distancing. Additionally, recent COVID-19 surges have created a second wave of need for telehealth in many CF centers across the country. And while we're all familiar with the challenges that telehealth has set up for us, I think there are also a lot of opportunities that we can talk about, such as the opportunity to provide an innovative new care model, as well as different ways to connect with our patients and more opportunities to strengthen our team. So I'll start off by talking about the program that I work in at UAB. We serve 278 adult patients, and our clinic schedule is 3 half-day clinics per week. We have 5 physicians and 3 nurse practitioners, as well as a social worker who's also our mental health coordinator. I'm the RD for our team. We have a pharmacist, a physical therapist, and several respiratory therapists that work with us as well. We're also fortunate enough to have a CF endocrinologist who comes to sit with us in our clinic 2 days a week. So, like most of the centers in the country, we made a full conversion to telehealth at the end of March 2020. We had previously been doing fully in-person visits, although we had discussed making a shift to telehealth or making that available to certain patients before the pandemic. And importantly, our care team disciplines were not able to be physically present on campus or in the CF clinic from March of 2020 all the way to March of 2021. So this created some difficulty in our team members all being split up. However, we were very fortunate that nobody was furloughed and we were all able to work from home. So with this, we developed a comprehensive communication plan so that we could know when to contact each other when visits were starting and ending, so we could try to mirror the seamless sequential visits of us rotating in and out of rooms for in-person care and translate that over to telehealth. So I wanted to show this graph to give you an idea of the volume in our clinic And this is a graph of the total number of CF clinic visits completed. And this is all types of visits from in-person to telehealth to our combination of both types of visits. And it's a time period of April 20th to current through September of 2021. And you can see that our average is around 80 clinic visits per month. We have a few months where we were really high on clinic visits and a couple of months like April of 2020 and July of this year where we were a little bit lower. But on average, we were doing about 80 clinic visits per month. So this is the percentage of those visits that were telehealth starting in April 2020 going through September of 2021. And you can see when the pandemic first began, we were doing 100% of our visits as telehealth for several months. This did drop down to about 80% over the summer of 2020, and it hovered there until March of 2021. And in March of 2021, our care team disciplines were able to return to clinic. We were doing, more than 50% of our patients were in person at that point. All of us had been vaccinated on our team, and many of our patients were starting to get vaccinated. Case numbers were lower. It seemed safe to kind of come back and do things in person again. And you can see that the rate of telehealth visits declined steadily between March and July of 2021. And we have now increased back to about 60% of our visits from telehealth due to the COVID surge that we've been experiencing in Alabama. We've had worse numbers as far as hospitalization and case positivity rate now than we did back in the early days of the pandemic. So our institution suggested that we switch everybody that we could over to telehealth. And I imagine that this telehealth push will continue through the end of the year to account for flu season, just depending on what COVID numbers do. So with this rapid shift to telehealth, we felt like it was really important to understand the patient and family experience of care. You'll probably recall that the CF Foundation had a patient and family experience of care survey called the PFEC, but that had stopped when COVID started and all this telehealth stuff happened. So we decided to convene a multidisciplinary group of stakeholders to design our own telehealth patient and family experience of care survey. So we came up with 21 questions framed towards adults. And some of the topics on our survey included satisfaction with telehealth, how convenient it was, whether or not patients were concerned over a lack of home remote monitoring, technical difficulties they might experience, as well as access to our CF care team disciplines. So then Boston Children's Hospital joined us as a pediatric site. They were really interested in participating in the survey with us, and they helped to develop the pediatric version of our 21 question survey. And very soon after that, we had many other teams join us from the Cystic Fibrosis Learning Network. And at one point, we were up to 14 centers participating in deploying the survey, which was really awesome. And it all happened so fast. And it was just a wonderful working group of people that came together to try to incorporate patient and family voice into how we were providing telehealth care. So the survey was deployed via text and email between April and July of 2020, so very early in the pandemic. And we were able to collect over 250 responses in this time frame, 141 from adults and 120 from parents of pediatric patients with CF. So to share some of the results, we found high levels of satisfaction and high levels of convenience reported in both pediatric and adult populations. We can see that about 3/4 of both peds and adults reported that they had a high level of satisfaction with telehealth care. The majority of both groups reported that they felt all issues and concerns were addressed during the visit, that they had adequate time to speak with the care team, and they were able to see all of the care team disciplines that they wanted to. Only 13% of each group reported difficulty accessing the visits. This was largely due to technological issues like poor internet connection on either our end or their end, or platform difficulties and having a hard time understanding the platform. And important to note is that, again, about 3/4 of both groups had no prior telehealth experience. This isn't surprising since this sample was collected early in the pandemic, and many centers were likely not using telehealth in a multidisciplinary way prior to COVID-19. We also wanted to understand how patients viewed the future of telehealth and if they wanted to engage in telehealth visits in the future in a post-pandemic era. We did find that the majority of participants in the sample indicated interest in continuing to use telehealth in the future. We found this on both the pediatric and the adult side. And you can see here on this graph that only 7% of adults and only 5% of parents of pediatric patients said that they would want no visits to be conducted over telehealth in the future. We also found that most participants expressed interest in home spirometry, despite low levels of concern over the lack of home remote monitoring that were reported in this survey. So we also were fortunate in our center to be able to work on a project with the CF Foundation State of Care Survey analysis. And we looked at patient and family experience of care. So the CF Foundation State of Care Survey was deployed between August and October of 2020. So still relatively early in the pandemic, pre-vaccines, but later than our multi-site experience of care survey. And 328 respondents reported that they had a telehealth visit. And the majority, which was up to 96%, found that telehealth was easy to use. And 66% of respondents reported similar or higher quality of telehealth in-person care. 1/3 reported the highest desire for future telehealth care, with 45% desiring half or more of their visits to be conducted during telehealth. This is a little bit different than what we found in our survey, especially because adults were more likely than parents to report the highest desire for future telehealth, with 64% of adults reporting that versus 36% of parents of pediatric patients. So this displays sort of the age group difference in perception there. Both of these surveys identified several barriers related to telehealth that if you've been practicing this in your center, I'm sure you've identified as well and heard patients talk about. There was some concern over lack of home remote monitoring, such as pulmonary function testing, microbiology, and pulse oximetry, as well as technological issues were reported that ended in sometimes visits having to be terminated or conducted only over the phone. And some barriers reported by both patients and in staff surveys were integration of the multidisciplinary team for optimal flow of the telehealth visits. We had several narrative comments in our survey about this and feeling as though things were disjointed or visits weren't condensed enough. So some solutions that we've proposed are the development of a comprehensive home remote monitoring program or programs. The CF Foundation was great in that they provided home spirometers for patients during the pandemic. We also need to work to make sure that all patients have scales and or have some kind of access to mail-in sputum kits or drive-through sputum kits. And this likely looks different at every center, but I think you're going to hear a little bit about home spirometry in one of the other talks in this workshop. Other solutions include improving access to high-speed internet and providing some comprehensive technical troubleshooting across multiple platforms. And finally, we do need more research and quality improvement projects to establish the optimal process for multidisciplinary telehealth visits. And again, this will likely look different at each center. And you have 4 other speakers in this workshop who are going to share with you their best practices. So in conclusion, the work from both of these surveys taught us that the perception of telehealth is overall positive in the CF population, at least in these samples. And there is patient and family desire for future use of telehealth, particularly among adults with CF. So with that, the frequency and the mix of telehealth visits likely needs to be different for the pediatric and adult populations. So where are we going with the future of telehealth in CF? This is such an exciting time and such an exciting topic to talk about because telehealth can really provide continued access to this high level of interdisciplinary care that we've been providing for people with CF and their families. And it's not only useful in the COVID-19 pandemic and subsequent surges, but could also be useful during flu season and for different types of CF visits. One major advantage is the convenience of telehealth and potential for cost reduction with traveling. And this is especially true for patients with financial difficulties or who have to travel long distances to their CF care centers. There's potential for replacing some routine in-person visits with telehealth, especially for patients who are clinically stable, but we do need more research on how to best incorporate telehealth into the CF care model. And future work should focus on long-term follow-up regarding patient and family perceptions of telehealth after frequent utilization. Much of this work was done early on in the pandemic. So with that, the CF Foundation is launching a new and improved patient and family experience of care survey. It's set to go live on October 25th. So if you don't know about this or you want more information, please visit mycff.org to learn more about this. And finally, I wanted to express gratitude to the people with CF and their families that responded to these telehealth experience of care surveys, and also to the CF Foundation, the Cystic Fibrosis Learning Network, and all of the centers that participated in these projects. And thank you so much for coming to my talk. I look forward to your questions and discussion.
Juliana, thank you. That was a great talk, great presentation. Appreciate it. There are a few questions that I have for you. What do you think the biggest change was with patients and families? You had mentioned that there was a second wave of COVID and you needed to revert back to all telehealth. What do you think that, what was the biggest change that you saw when you went from the first one to the second one? You must have been more prepared.
Yeah, we were definitely a lot more prepared, Kate. I think that the biggest change, at least from a staff perspective on our team, when we entered the second COVID wave, was that we had all of our clinical staff physically in the CF clinic. Even if we were doing telehealth visits, we were all in one place together instead of having, us all being split up and having this really complicated communication chain between me and the physician and the social worker and the respiratory therapist, us all scrambling to message each other when we were done and when another person could start. It made the flow a lot easier to have all of the disciplines and our entire multidisciplinary team in the same space during the second wave. And, we were all vaccinated at that point and obviously still wearing masks. So it felt a lot safer that time. And patients and families and some of our follow-up experience of care surveys that we sent indicated that they felt like things flowed better when the team was all together in clinic versus being split up at home.
Yeah, that must have, we haven't experienced that in Boston. That must have been really difficult to have to go back after being out for so long and then back in and then have to go back virtual. Are you still virtual now?
We still have a mix right now. We have a mix. I think the last I looked, we were about 50-50.
Wow.
Starting to do a few more in person.
Yeah. So you can do some in person?
We can. Even when we went back into the second wave, we're in that surge. We did keep some visits as in person because we had people that we hadn't seen in over a year. We didn't even have a home spirometry measure on, or they were having some type of active clinical issue that would have, really required a good physical exam and laying eyes on the patient. So I think that we were a little less strict about just converting everybody back to telehealth when we had that surge come through.
And another question was for telehealth and your team. How did you find that the telehealth, you mentioned that it strengthened your team. Tell me a little bit about that, can you?
Yeah, sure. So I feel like because we were all split up in these different locations, to really focus more on communication and be more intentional and really clear with our communication with one another. And not that we were bad at it before, but I just feel like it got better because we were all having to think about it so much more and connect so much more frequently. So I feel like that was a huge asset. There was also just a real sense of camaraderie and us all being in it together. And, everyone supporting one another during what were all of the challenges of the pandemic, including like work-life challenges and, the things that we all experienced collectively.
And for Juliana, this is a question about research. One in Slido saying a great presentation, Juliana, which we all agree. Were you able to include the research staff in the multidisciplinary approach so they could speak with the patients about ongoing research opportunities? And if so, how did that work?
You know, I feel like while we didn't include research staff in our surveys that we sent to staff on a staff experience of care, and we probably should have, I feel like we stayed in really close contact with our research coordinators during all of this. Our center was a site for the PROMISE study. So we were kind of in constant contact with the lead coordinator on that study about home spirometry and any other studies that required pulmonary function testing. And we also worked pretty hard to coordinate if there was going to be an in-person clinic visit, coordinating that with our research staff to make everything easier on both them and the patients for sort of lumping things together. And with the COVID testing that we had to do before research visits and clinic visits, and anytime somebody did a Spiro. So I would say that we were able to keep them pretty incorporated into our multidisciplinary team.
Thank you. And then, Juliana, do your providers at UAB view the experience with telehealth as favorably as patients do? And will you be able to provide sustainability moving forward, thinking about reimbursement issues?
Right, those are great questions. So we actually also conducted a staff experience of care survey as part of this project it's been published as well in a separate manuscript. And staff at all of these centers did have a favorable view of telehealth. We did find that staff had more comments about concern over home remote monitoring. Like the staff, particularly the pulmonologists and respiratory therapists, were more concerned about the lack of PFTs than patients expressed on our Likert scales. And looking at the second part of that question, sustainability, I think that's kind of on everyone's mind. We have some physicians working with a reimbursement committee at our institution to try to make this something that's sustainable, particularly with home spirometry and being able to bill for that. And I know someone else is speaking in this workshop about home spiro, so I wonder if maybe they'll touch on that a little bit in their talk as well.
Yes, I think they are. Then can you expand a little bit about the experience of care and that survey that is going out? You said that it was, or we have all seen it at our centers. It started, I think, last week. You said October 25th.
Yeah, I would love to talk about the experience of care survey. One of our other speakers in this workshop, Dr. Euler, is also on the steering committee for the experience of care survey work that we're doing with the CF Foundation. So as most of you have probably heard, that launched on October 25th. And this is a comprehensive experience of care survey that covers both in-person and telehealth visits. We have made this survey shortened, and it's also a lot easier for patients and families to complete the survey now. Once you enter your patient and family's contact information into CF Smart Reports using the patient contact tool, after a Port CF encounter registry encounter is open for those patients, it causes the survey to fire to their cell phone as a SMS text message or also an email. So it's way easier for the patients to take this. It's way easier for centers to get involved because it's as simple as entering your patient and family cell phone and email addresses into CF Smart Reports. And there's also a new and improved interactive dashboard that comes along with this survey that allows you to really slice and dice your data for your program and get some pretty real-time results, as well as narrative comments, and make really great data displays. So I would encourage everybody, if you haven't entered your patient contact information into CF Smart Reports, we do have resources on mycff.org for how to do that, a step-by-step guide. And I would encourage you to do it. And we'd love to get as many programs as possible participating in this experience of care survey, because we really feel like it's really a way to partner more deeply with our patients and at a national level. And the feedback that we get from patients and families on their experience of care can really complement the clinical data that we collect in the CF patient registry. So again, mycff.org for resources and more information about the XOC survey.
Sounds wonderful. Thank you. And then there's one last question I think we have time for from the Slido. What disciplines on the team were able to bill for services, or is your telehealth visit considered a bundle visit and only provider can submit a professional level of service?
That's a great question, and I bet this looks different at every center. At our center, we were considered a bundled visit. Disciplines didn't bill individually for their visits, and only the provider could submit for reimbursement for that. However, because we, as the disciplines, myself and the social worker, especially because we don't bill, we were able to we still could use the telehealth platform to conduct telehealth visits and, document in the EMR after those, but we're fortunate in that we did not have to bill for those visits.
I think that's all the questions that we have. Juliana, we want to thank you very much for your presentation and for participating, and I hope you enjoy the rest of your conference.
Thank you so much for having me, Kate.
Okay, our next speaker is Jennifer Hamilton. Jennifer is a NP at the Intermountain Pediatric CF Center in Salt Lake. Her talk today is Transition to Multidisciplinary Telehome and Hybrid Clinic Appointments. Thank you very much, Jennifer.
Hi, thank you for this opportunity to present at the workshop, The Future is Now, Innovations in Outpatient Care, Telehealth, and Everything in Between. So I'm going to present on transition to multidisciplinary telehealth and hybrid clinic appointments. It is poster 66. I'm Jennifer Hamilton. I'm a pediatric nurse practitioner at the Intermountain Cystic Fibrosis Center, and I am also faculty with the University of Utah's College of Nursing in Salt Lake City, Utah. I have no relationships to disclose related to this presentation. So the first thing to discuss is to give you a little background on our transition to multidisciplinary telehome and hybrid clinic appointments. The COVID-19 pandemic necessitated the rapid transition from in-person multidisciplinary visits to telehome and hybrid clinic appointments at our large pediatric cystic fibrosis center in the Intermountain West. And to give you a definition, we defined hybrid clinic appointments as some of the CF care team members seeing the patient in person in clinic and others by telehealth, either a visit by phone or by a video platform, either the same day or within a week of their scheduled visit with the provider. Prior to the pandemic, we had not utilized video platforms or these asynchronous visit styles methods. Multiple PDSA cycles were utilized to implement rapid changes and evaluate their effectiveness. The CFQI team met 1 to 2 times a week to review, improve, and test PDSA cycles. Our QI team is a multidisciplinary team that consists of providers, including physicians and NPs, nursing staff, our pharmacy tech, dietitians, social work, as well as 2 parents of children with cystic fibrosis. These telehealth and hybrid clinic appointments were evaluated for feedback through a survey created by a collaborating CF center, and these were sent to all clinic visits between June and November 2020. This is kind of a flow demographic of how we implemented telehome and hybrid clinic appointments. Initially, staff received training, and we adopted a video platform that was supported by our healthcare system and was HIPAA compliant. We first had a synchronous visit with a medical assistant, a CF provider, and an RN. And when I say CF provider, I mean pulmonologist or nurse practitioner. Then synchronous visits were expanded to include additional and eventually all multidisciplinary team members, including pharmacists, dietitians, social work, our physical therapist, our psychologist, and others. The CF team members communicated with each other during these clinic visits via a HIPAA-compliant virtual chat separate from the telehealth platform. Many of us were working from home, and so we would utilize this platform to communicate when it was time for the next individual to enter the virtual CF clinic appointment or to communicate pertinent clinical information such as enzyme dosing or other patient information. Age-appropriate materials were provided to patients for home monitoring with written documents and videos to educate patients and families on correct use. So as we implemented things like infant scales at home and home spirometry, we had to provide information to families on how to utilize an infant scale and gather an infant height at home, as well as how to weigh a child and get a height measurement for a standing child. And so these were provided to the patients and families as needed. Data from home equipment was collected during telehealth visits and used in clinical decision-making. So we would use spirometry to decide whether to treat a pulmonary exacerbation. We would use weight measurements to change enzyme doses or implement further nutritional interventions. And then with time, other video platforms were trialed and utilized based on institutional compliance and ease of use. So we are now currently on our third platform, and we are finding this one the most efficient. So here are results in a bar graph form. So as you can see on the bottom axis, there is the date, and then on the vertical axis, there is the number of appointments. So these are individual patient appointments. Blue lines are telehome and orange lines are hybrid visits. And you can see initially in March, we did a pilot telehome with this provider. And then we started adding the multidisciplinary team in April. We piloted a hybrid visit. So the patients were brought back into clinic, but not all the team members were. And we had a big dip in July in appointments, and we initiated scheduling meetings to try and minimize the impact of scheduling issues on our ability to see and manage patients in clinic. And you can see after the initial period of kind of adjustment, hybrid visits and telehome visits were fairly equal through the fall and winter. So in 12 months, we had 1,116 encounters. 56.36% of these patients were seen in telehealth encounters, and 43.64% of these patients were in hybrid encounters. So the vast majority were telehealth during that time. From March 18th to April 24th, 2020, 100% of our appointments were telehealth. We were not seeing any patients or minimally seeing patients in clinic at that time. In March 2021, so a year later after implementation, 31.25% of the appointments were telehealth, and the vast majority had now switched to hybrid, 68.75%. Hybrid appointments were discontinued June 2021 as all the team members were invited back to the clinical space, and we went from having telehealth and hybrid appointments to having telehome and all in-person appointments. So these are the results of our survey. We had fairly low response numbers. So our telehealth responses, we had 23. 95% reported they were able to see all the team members that they wanted to. 91% said they were mostly satisfied or satisfied with their overall treatment experience. 87% felt like it was a convenient method of receiving patient care. 100% felt that all their issues and concerns were addressed. A very small amount, 8.6 or 2 responses, would rather not have any CF care via telehealth. So that was interesting. Hybrid responses, we only had 9. 100% were very satisfied with the format, and 100% agreed or strongly agreed that all their issues and concerns were addressed. In conclusion, through rapid PDSA cycle testing and change implementation, we were able as a team to implement multidisciplinary telehealth and hybrid clinic appointments in a fairly efficient and effective manner. There were some issues with obtaining cultures, and you can see our poster 71 about how we did that process. Informal feedback from the team was mixed. Some team members really felt that telehome visits were effective. Others felt less so. The hybrid was equally mixed. Some team members felt like their interactions were better with patients in person versus hybrid. And survey responses were low, especially those for hybrid visits, but those that we received were positive. And so we felt like we were meeting patient needs during a difficult time. I would like to acknowledge the Cystic Fibrosis Learning Network Telehealth iLab for their guidance, and to the University of Alabama at Birmingham CF Center for sharing their telehealth and hybrid clinic survey. I'd also like to acknowledge our multidisciplinary CF clinic QI team, who strives really hard to improve care for patients, as well as all our patients and their families. They really worked with us during this difficult time and adapted as we adapted. Thank you for this opportunity to present our work. I hope you enjoy the conference.
Thank you, Jennifer. That was great. Appreciate you taking the time to present your information on your telehealth visits. You mentioned that your institution provided training in telehealth. Can you tell us a little bit about that training? And I think a lot of our institutions kind of left it up to ourselves. And so I'm interested to hear what training you had.
Yeah, so our institution provided some training on their specific platforms. And so we were able to utilize those platforms and have some training from trainers. The platform had been used like in urgent care settings with the institution, so there were already some trainers involved. The training was fairly limited. It was remote. I think it was like a 30-minute video and then like a 15-minute kind of hands-on remote session with a specific trainer. If I'm remembering correctly, there was a lot that happened in that March, April 2020. There were always people available for support as well. And then fortunately, we did have a couple staff members who just seemed to be very technology proficient, who, though not designated or specially trained, acted as informal tech support. So there was a lot of that as well. One of our team members, our pharmacist, was the one who had this idea to use a Microsoft Teams product that was HIPAA compliant for our kind of team chat that was separate from the patient. And so we just tried to use everyone's skills and strengths to cobble together something that was efficient and worked for us. But we were fortunate to have some training, though, because our institution was kind of, I guess, into telehealth, for lack of a better term. We're on our third platform currently. Every time we switched platforms, they did provide training, but it has been kind of difficult to switch platforms. But this final platform has been much more, I think, family friendly, and probably about the same for our staff.
Okay, and from Slido here, question, please define what your hybrid appointments were and what they consisted of.
Yeah, so the hybrid appointments, the patients would come in person, and the medical assistant, the nurse, and the provider, which was either an NP or a pulmonologist. And sometimes we had our provider clinics where we had a gastroenterologist or an endocrinologist as well, would see the patient in person. Sometimes there were PFTs done, sometimes there weren't, kind of depending on the patient need and where we were in the pandemic. Earlier on, there was very few PFTs in person, and then later that increased slowly. And then some of our staff would remote in, so we would use an iPad in the room. Fortunately, we already had iPads in our patient rooms that had been created to kind of let the patients utilize technology or games while they waited in between people. So this was already structure in place prior to the pandemic, but we used these iPads then to do a video in for the dietitian, the pharmacist, the pharm tech, the mental health provider, either a psychologist or social worker. So we try to get all those disciplines in. At the beginning of the pandemic, we did consider a hybrid appointment something that occurred even if it was a phone call made within a week of the visit by another team member. So initially at the beginning of the pandemic, we were trying to figure this out. The dietitian would call like the next day or 3 days later. But when we got more formalized and more proficient, it was all same day. I hope that was helpful. Do I need to clarify more? Okay.
No, I think that's it. You said that you're not doing virtual anymore. Do you see that as, so there are no more virtual appointments at your center now?
We are still doing telehealth, telehome, whatever terminology you want to use, but we're no longer doing hybrid.
So all
I
the
see.
staff is in person, and our clinics are no longer separated. We used to have a designated like telehealth clinic where all the patients were just telehealth that clinic, that half day. Now we are intermixed. And so some patients are coming in person and some patients that we're doing telehealth with. And we have the telehealth set up in a patient exam room, and each provider just goes or team member goes to the room to do their portion of the visit. So we're no longer doing the quote unquote hybrid, but we are still doing telehealth.
I see. Inside of, there's two questions. Is telehealth appointment still an option for your patients? And what platform are you currently using? You said you went through 3.
Yeah, so telehealth is still an option. We're really trying to define it. We have 4 providers to do CF, and we've always tried to maintain consistency between the 4 providers because we don't have our own panel. We all share patients. So we've currently come up with a model. If the patient is stable and they prefer, we are doing telehealth, and we have a provider licensed in their state because we cover 3-4 states. We are doing telehealth every other visit. But we were finding some patients we hadn't seen in person in almost a year. So we're not allowing them or recommending to do telehealth every visit anymore. We're at the point where we're recommending every other. Granted, if things change related to the pandemic, we always have the ability to adapt that as well. And our current platform, oh my goodness, I think it's video via. It's through our EHR, which makes it really helpful. I don't have to go to a separate window. I do it through our EHR. And I can't remember exactly what it is.
That's okay.
So.
That's okay. Can I ask you, there's another question on how did you support your team members and patients and families with limited comfort with technology or access issues?
Yeah, so our newest platform we're using is very nice because it can use cell phone data, not just Wi-Fi data. So that was really helpful for our patients in rural communities who did not have high quality Wi-Fi access, because that was a big issue. And some of those patients, we weren't able to do telehealth with a video visit. We had to switch to just a phone call, which really isn't a very good visit in my opinion. So that helps that we have this new platform which can work over cellular data as well. Our staff that wasn't as comfortable, we had the opportunity to put them through more training formally. And then we also had, our informal champions who would, when people were all at home, like call them and kind of walk them through the process. When it's in person, our medical assistant does a lot of the setup. So that's kind of eliminated that issue now that we're doing these like telehealth within our institution's building. So I think that's one of the big issues with a rural population is the Wi-Fi access.
Yes, yes. And then we have one more question. In your opinion, do you think the home measurements and home spirometry and cultures were accurate for clinical decision making? And was there the comfort level of your team?
There was a wide variety, and definitely we kind of looked against prior information. So if a child grew dramatically or gained a ton of weight, I think we questioned those. But if it seemed within typical growth patterns, I think we questioned those less. We did use some local funds and provide an infant scale to all our patients. And now we've started that as our newborn process. And so I feel like our infant weights are probably pretty accurate because we've provided those measurement tools. And we've also provided YouTube videos on how to weigh it and measure your infant. Definitely kind of the standing almost seems trickier measurements. And then home spirometry, it seems like for some patients, they're very consistent with their home spirometry. And it seems like the older the patient, I'm in a pediatric setting, so the older teens were very consistent. The younger kids were trickier, but fortunately we have a nice RT support. So we were able to have them sometimes do like video visits to kind of go through technique and double check. And so definitely that kind of helps. Cultures we've worried about, definitely because we had parents attempt to get cultures. If you look at that other poster, I talk about that process more. And so we did wonder about that. And so there are a lot of kind of questions and variations. Some of our families loved it and some of our families prefer in person. It looks like there was a question about patients resistant return to clinic. We definitely have some families who are like, I don't want to travel, because we have families who will travel 6 hours, 4 hours out of state. And so some families really do not want to travel. We have one state which we see patients in that none of us are currently licensed in. It just wasn't, we had such a low volume of patients there, and it was expensive that none of the providers are licensed there. And I know those families wish they had more access. It's just hard from an institutional standpoint to have providers licensed in 4 states. And we use Cerner as our EHR.
Thank you very much. Great presentation. We really appreciate you taking the time to be part of this workshop, Jennifer. We're going to move on to our next speaker. Thank you.
Thank you.
Our next speaker is Martina Campton, who has many years of experience in the care and manage of both the pediatric and the adult patients at UVA in Charlottesville. Her talk today is entitled Home Spirometry Utilization in Telemedicine Clinic for Cystic Fibrosis during care during COVID-19. And a quality improvement process.
Hi, my name is Martina Compton, and I'm a respiratory therapist for the University of Virginia and the Adult CF Center. My topic today is home spirometry utilization in telemedicine clinic for cystic fibrosis care during COVID-19 pandemic. I have no relationships to disclose related to this presentation. Now, as many of you did, our adult team had to quickly transition to telehealth in March of 2020 when our clinics shut down. And the CF chronic care guidelines recommend monitoring spirometry during quarterly visits to identify early lung function decline. So we knew if we wanted to continue that quality care for our patients, we had to act quickly. We needed to implement remote monitoring, creating new modes of communication between members of our staff. We wanted to purchase and distribute home spirometers, and then all of the coaching and education that goes along with those had to be done. We were fortunate in that we had a home spirometry program in place in 2017 through the Circle of Care grant, who funded us 48 home spirometers. During that time, we were also able to do same-day comparisons between the home spirometers and clinic spirometry. So this gave us confidence in our results and our patients also. So a big jump on this when the pandemic came along. So in March of 2020, we added 70 home spirometers. The Mir Smart ones are the ones we purchased. At the time, we did not know they were coming from Italy, so there was a little holdup in customs, but we did start being able to hand them out around mid-April. And this chart highlights why we were so invested in this project, because we utilize telehealth quite a lot. We used it prior to the pandemic for patients who were far away, and we went straight to telehealth mid-March of 2020, and then only saw acute patients for a while until clinics really opened up, and all of our team members stayed virtual pretty much for an entire year. And our patients really are comfortable with telehealth, and some of them prefer it. Our SMART aims for this project were, of course, to first give out home spirometers to all of our eligible patients, which we started with 37% of them owning a home spirometer. We wanted to increase to 85%. And then, of course, we wanted to increase utilization of these devices from 50% in March, which was pretty incredible, to 95% by the end of the year. And so we began distribution and training of these devices, We started with curbside pickups. Patients would drive by and I would drop the spirometer in their front car seat. We did not offer curly fries, but we did offer sputum cups. So now we had a lot of different spirometers. We needed baselines on these, and we needed to teach them and educate our patients. This is quite a juggling act for the respiratory therapists. We had the 34 baselines from the early spirometers, but now we had many more, and we needed to get baselines on these. We had our patients do 1 to 2 tests a week if they would. Some did not and didn't never open their spirometer box until they came to their first virtual visit. But we decided to focus on discrepancies 5% or greater. And when that happened, we would do a deeper dive into what was going on with the patient. So this is our process for that. I receive results that are 5% or more below the patient's baseline. So then I'm going to ask them about their symptoms if I haven't already done that. If they have a lot of symptoms and we feel like these are real results, then we'll flag that as an FIES and with symptoms and send that to the physician. FIS stands for FEV1 indicated exacerbation signal. If they didn't have any symptoms and we have to dig a little deeper, did they use their albuterol, which is what we asked them to do prior to their testing? If yes, great, then we do a repeat coaching with me virtually. If the test is back up to their baseline, then we're good to go. Send those results to the physician. If we are not back up to baseline, we're still 5% or greater below, then we flag that as an FIS without symptoms, send that to the physician. Now, if they did not use their albuterol, then we'll ask them to do that during the visit. And then I'll come back on 20 minutes later and repeat coaching with them. If their results are back up to baseline, they're good to go. If they are 5% or less, then we'll flag that as an FIES without symptoms and send that result to the physician. Now, this is where all the results go. This is where so much information that we have during clinic goes. It is our real-time tracking sheet, and it is shared with all the team members, and it can be populated simultaneously. So I put the day's results here. You can see it in the green, and that is below where I previously posted their current baseline and their 10% drop threshold for FIES. And in this one, the patient is color-coded green because they were above their baseline. They could be yellow when they are 5 to 9% below, or red when they are greater than 9% below baseline. Now, we utilize the FIES just like we do in clinic with the home spirometries. There may be a difference in their baseline with their home spirometer than clinic, but that's okay as long as we know what that difference is and we know what to expect when they're at home doing the test. If we receive a test that's below baseline, they're going to do a deeper dive and consider all of these things. There's symptoms, of course. When we do recoach the spirometry, we're going to look at their effort. We're going to check their equipment. Did they lock their turbine in correctly? Did they put the mouthpiece in far enough? Are there other causes that could be happening, such as asthma? And that's why we ask them to do the albuterol. Their environment is another issue. If you have a fan going overhead, it could skew the results. Or maybe they just woke up from bed and just aren't quite awake yet. So this wasn't easy. There were many barriers, many of them listed here. Loss of mouthpieces, loss of devices that weren't charged. We had some people who didn't have good Wi-Fi connection, and there were some that just did not trust their results. So our solution to these, we ordered some spare mouthpieces to have on hand. We sent reminders to patients through their PVP to have all their equipment ready to take the albuterol. We ordered some microlife spirometers for those who did not have a smartphone. We verified some people's results in clinic when we were able. And we helped with finding Wi-Fi connection. Actually, our patients were really good at figuring this out, going to schools, community centers, maybe their parents' house, anywhere they can find a better connection. So how do we do? Our percent of eligible patients who owned a home spirometer, we achieved that goal by July with 86% in 2020. And then we slowly trickled up. And by February of 21, we had 99%. And we're pretty much stay there. We have some eligible patients who have some ineligible patients that have may have a disability of some sort that keeps them from doing it. But it's just a handful of our patients that don't have one. Utilization of these devices. Also, we achieved our goal by October with 96%, and then November we had 100%. And we dipped down a little during the holidays when people forgot their devices at home or at their parents' house when they were visiting. But then we were right back up to 100% in March, and we pretty much stayed there, maybe dipped down just a couple percent here and there. And this is monitoring our system. This is a control chart. And you can see the blue diamonds that from the beginning, they slowly increase and then become pretty steady. The bubbles are interventions that we made to get to that point. And then you can see where the control limits get tighter and tighter and shows that this is a reliable process. Suggestions. Really important to build trust into your program. Have your patients bring those devices into clinic to validate the results and compare with the clinic results. Do the virtual training one-on-one, separate from clinic or during clinic, or you can even do it in groups of patients. Use shared decision-making. You really want to be a part of your care. Everybody does. And if you just talk to them about their symptoms and they see their results, they come to the same conclusion as you do. Yeah, I'm in an exacerbation today. Just really encourage that self-awareness with the data. Education materials, also very important. We had different pamphlets that taught how to use each one of our devices, and we have 4 different ones. So more tips, of course, the Wi-Fi connection, reminders through that pre-visit planning is so helpful to have everything ready for clinic. Sharing their results. If you don't want to use the portal, we do not use it. We use screenshots that we take during clinic, secure text messages, MyChart messages if they want to do them ahead of time and send to us. Use your tech support. Use different modes of instruction. Some people are great with a pamphlet and they can learn how to do it at home, but others might need you to have them come into clinic and teach them there. When you're trying to establish that baseline, phone reminders are good to tell them when to do the test or tie it in with other habits that they have at home, such as brushing their teeth. Now, this is quite the complicated process, and it does require provider-patient co-production. It requires a designated person to coach the patients, make the educational materials, send all the information out, receive and record the test. It's pretty time-consuming. But our team feels like using home devices via telemedicine is reliable, sustainable, and it can be replicated across centers that provide care for patients with CF. Our next steps are just to continue on as we are doing with telehealth, having the patients bring the devices into clinic and validating those results as often as they can, and just continue as we are doing. I want to send a big shout out to my adult CF team and thank them for all of their encouragement and support through this whole process. And I also want to thank the CF Foundation. This project was supported in part by an award from them. And I also want to thank them for handing out home spirometers across the country in the past year. Thank you so very much.
Martina, I applaud you on all of your hard work. Great presentation, great data. I was particularly amazed at how much you were able to accomplish in such a short time, and going from about 40% of your population getting spirometry in a very quick time to 97, 98, which is amazing. And also all of your data is very impressive. We do have a few questions for you. The first one is from Slido is, thank you for sharing your experience with us. Did you have trouble with patients being able to perform ATS acceptable at your sessions? If so, what was your process for improving technique?
Thank you, Kate. Well, there were there was a couple that were really unable to do the test very well. If I saw any issues with their testing, we usually had a virtual visit. I coached them during the visits when they came in. I mean, when we saw them on telehealth, I coached them. And remember, we had 48 spirometers prior to the pandemic that we already taught in person and compared with clinic spirometry. So that, gave us a really good jump start for everything. But just the same kind of things that you do when you're in the PFT lab, same kind of instruction.
Right. You mentioned that you created tools for each of the spirometries that you use. Is that something that you would think about sharing and having them so that other centers could use them?
Oh, yeah, sure. I think for the Spirobank, the Zephyrx people made their own eventually, but we made ours first before I saw that one come out. And it's really just a nice little folded up pamphlet. And yeah, I'm happy to share it. And
yeah, I
so
know
we had
the educational committee for the CF Foundation, I think, would really appreciate that. For other centers, I think it would be great. Thank you. And there's another question in Slido. If you have patients transfer into your center, do you automatically order them a device if they don't already have one?
Yes, we don't. Well, we don't necessarily order one. We still have spirometers to give away. I think I still have about 8 or 9.
Wow.
And we've had quite a few new patients transfer in or new diagnoses, and they all have spirometers too.
What funds do you utilize to purchase the home spirometry and equipment for your patients?
When we got the first bunch, I think I said it was the Circle of Care grant money is where we did that. And I think it was the same for the second bunch that we got. So the 70 that we got in March, I believe, of 2020 are different from what everybody else is used to. They only give the FEV1. But the thing I love about them is they seem as accurate as anything. And they're so easy to use. They're really great for the patients that have low lung function because they're so easy. You just have to blow in like a 1 to 2 seconds 3 times and you're done. So not that big long exhale, which, we do want all that information, but they have been very accurate.
Right. That's great to hear. How many patients have the spirometry at this time?
I think it's still right at 99%.
Percentage-wise for your clinic, about how many?
We now have 160.
Mm-hmm.
patients, which is a big jump from where we were when we started with the spirometry thing. I don't know the exact number anymore. It's changed so dramatically in the last year.
Right.
But yeah, we're right at 99%. I mean, there's nobody new that doesn't have one. So.
And another question is, do your families bring, you mentioned that they bring in their home spirometry so you can check it. Do they bring in their other equipment with them? Is it all done at the same time? As a respiratory therapist, do you look at what their vest settings are, as well as if their nebulizers are working or their compressors? Or, I mean, I love the idea that they're bringing them in.
Well, on the adult side, no. I'm lucky if they bring in the spirometer.
Okay.
So before the pandemic, I was already doing telehealth with adult patients and watching them do all of their treatments at home. On the pediatric side, we did have them bring all of their equipment in. We have stopped doing that since the pandemic, but we've actually talked lately about getting back into that.
And two questions in one. How often do you ask your patients to measure their home spirometry and lung function when they're at home? And where do you see it moving in the future?
So I typically ask them to do it a couple of times a week for a couple of weeks initially and send me the results. And then it's, they can practice a couple of times, like once a month, but we really don't ask them to do it other than during exacerbations when we're trying to have a follow-up with spirometry or during a virtual visit. With the kids, it's a little different.
Yeah, it is. Along with the instructions, did you make all of the home spirometry appointments, reminders, phone confirmation, etc.? And did you make clinic appointments for each visit to document?
I'm not sure I really understand the question.
I guess, were you the sole person? If we break that down a little bit, I think what they're trying to say is, along with the instructions that you sent out and prepared, did you also have to make all of the home spirometry appointments? Or this must have been done during a clinic visit, right? That you would check it. And then, in other words, who was doing some of that administrative work for you, with you?
Anything that was separate from clinic, yes, I did myself. And for clinic, it was just, with their regular clinic visit. We just did it in the middle of the clinic visit, or at the beginning, actually. But yeah, no, I didn't have to make all the patient appointments. Right. Thank goodness.
Right. Thank goodness. Thank goodness. I think that's all the questions that we have for now. Really appreciate your talk and all of your effort and your work, and look forward to hearing more about how things go in the next year or two.
Thank you very much, Kate. Thanks for having me.
All right, you take care. We have our next speaker today is Andrea Moultson. Andrea is a research manager and a coordinator in quality improvement at the VCU in Richmond. Her talk and her poster is a comprehensive adaptive approach to effective telehealth in a pediatric CF clinic. We welcome Andrea. Thank you.
Hi, I'm Andrea Moultson. I manage research projects and serve as the QI lead for the Children's Hospital of Richmond at VCU's Pediatric CF program. I'll be presenting on our team's approach to telehealth, how we adapted to the virtual modality, and how we've continued to work on improving our program in general. My disclosures are that I receive funding support from the CF Foundation and from the CF Learning Network, which I'll refer to as CFLN for the rest of the presentation. Okay, to start, for a bit of context, I'll say that our patient population is fairly small. We have about 65 to 80 patients in a typical year. Before 2020, we had some success with implementing testing, tracking strategies to improve quality of care and patient health. But our QI efforts were mostly physician-led to that point. We hadn't been doing any sort of regular team-based QI work. At the start of 2020, we joined the CFLN, and this helped steer us toward a more broad, comprehensive, team-centered approach to QI planning. We started weekly QI team meetings before our pre-clinic meetings and started to brainstorm ways to improve our weekly clinics, not just from the provider standpoint, but from the patient standpoint as well. Of course, this was based on the assumption that our weekly clinics would continue as usual in person, but we all know that wasn't the case for very long. We actually didn't meet as a team to start on QI work until February, and we had just completed our first PDSA and finished onboarding our patient family partners, which we'll refer to as PFPs. When starting in the second week of March, we had to stop meeting in person and stop all in-person clinic visits due to COVID. And just to back up for a second, for reference, the CFLN defines the role of PFPs as committed full members of the programmer-centered team who co-develop initiatives with the team. And back in those early months when we were still meeting in person, scheduling conflicts pretty much prevented our PFPs from being able to join in our first QI team meetings and prevented collaboration early on with them. After everything switched to virtual, the care team was still meeting every week virtually, but at first we were more focused on how to start using telehealth right away, all of the logistics that entailed, than we were on QI work. However, it didn't take long for the dust to settle, and we quickly pivoted to focus our QI work on optimizing the virtual CF clinic experience. Okay, so our objectives were we wanted to be able to rapidly but effectively adapt to the switch to telehealth. We also wanted to continue QI planning to improve the overall quality of care that our center provides. We tried, and we're still trying to achieve these objectives in several strategic ways. First, we wanted to make sure that we were using the technology in the best way we could. So this in itself turned out to be a bit of a protracted process since our health system switched supported platforms a few times in those first few months of COVID before they settled on Zoom. But once we started using Zoom as our standard platform, we figured out how to use the different features of the program to maximize the virtual clinic experience for us and for our patients. Some of the features we found to be the most beneficial and that are now standard to all of our virtual clinic visits are the breakout rooms for individual patients and the waiting rooms. So our nurse manager stays in the waiting room for the duration of the day. When a patient logs into the clinic, they are immediately directed into the waiting room with the nurse manager, who then moves them to a room that has what we call pod nurse, who's going to check them in on our medical database, and she's going to get their vitals as well. Then that patient goes back into the waiting room with our nurse manager, who assigns that patient to an individual breakout room. The breakout room is labeled with the patient's first initial and last name. Meanwhile, the whole rest of the care team is in what we call the team room. It's all part of the same virtual Zoom meeting. And while they're in there, they can check the breakout rooms periodically to see who's present in each room. As soon as they see that a patient's entered a breakout room, if they are the first provider listed on that patient's schedule, they're meant to then head into the breakout room with that patient. And then the rest of the providers enter following the schedule for the rest of the day. That's how it progresses. The team members and the nurse manager can move in and out of any of the breakout rooms, into the waiting room and into the team room, but the patients are only able to go into the waiting room, which is the main meeting space, or into their own assigned breakout room. Okay, so one of the PDSA ramps that we've completed was for the purpose of reducing wait time so that patients aren't waiting a long time on Zoom in between providers. We wanted to make sure that that wait time was an average of 25% or less of their total visit time. Some of the ways that we found we were able to do this and achieve reliability was through improved monitoring of breakout rooms, improved team communication, and implementing line skipping, which basically just means that we make quick adjustments to a patient's schedule as needed to improve efficiency. Another thing that we've tried to do to incorporate more patient-family feedback, or another thing we've tried to do is to incorporate more patient-family feedback into our regular clinic planning. First, Through an iterative process of revisions made collaboratively by the team over time, we improved our patient pre-visit message to make it more like a form. A patient or a parent can download it, the pre-visit message, they can copy and paste it into Word, or they can copy and paste it into a mail document. And we have included preset check boxes to make it really easy for them to answer some of the basic questions that we have leading up to their visit, and submit that feedback to have their voice be included in our pre-visit planning. We also include some open-ended questions on our pre-visit message in case they want to provide any longer responses. We have customized our pre-visit message to make it more personalized per each patient. If a patient is due to complete either our mental health screeners or the social determinants of health screener, we include links to the red cap versions of that in their pre-visit message. If they are scheduled for a virtual visit, we also include a list of home health data that we'd like them to collect prior to their virtual visit. We let them know whether their visit is meant to be virtual or in person. And if they're scheduled for lab work, we give them information about that as well. And any responses that the nurse manager receives from those pre-visit messages from the patients, she reads out loud during our pre-visit team meetings, pre-clinic team meetings. Because our weekly QI meetings have been virtual as well, our PFPs have had a much easier time joining each week, and we've definitely benefited from their regular participation and collaboration with us. We adopted new strategies to improve and increase communication among team members and with patients. As an example, since we don't all work in the same shared space anymore, we found that a lot of the post-visit patient information that was typically shared casually among team members just wasn't being shared to the same degree anymore. So to help with this, we added an extra 30 minutes to our weekly team meetings so that the team could have a post-clinic meeting in addition to pre-clinic meetings. We can go over the patients from the previous week and talk about the upcoming patients. Also, we developed a post-visit summary template that each provider adds to for each of the patients they've seen in the previous week. Ideally, we want the providers to complete their sections within 1 week of clinic, and we review each of the patients' post-visit summaries as a team during our post-clinic meetings. After our post-clinic meetings, the nurse manager finalizes each of these documents and electronically sends them out to the patients from the previous week's clinic. And these just help to make sure that providers and patients all are staying on the same page when it comes to a patient's treatments, recommendations, reminders, current patient health stats, that kind of thing. The next thing on the list here is we wanted to make sure that our patients had all of the home equipment and tools they needed in order to be able to continue to monitor their health from home without having to come to clinic. Our center director and our lead respiratory therapist, or RT, worked really hard to secure funds and equip all age-eligible patients with home spirometers. They nearly accomplished this within the first 6 months of COVID, and by 9 months in, this was fully accomplished 100% of patients. At the same time, our dietitian worked to make sure that all of the families who said they didn't have a home scale and weren't able to purchase one were sent one by our center using our center funds, and the same for tape measures for measuring height. Our nurse manager has worked continuously, still is, to acquire and mail out throat swab kits to collect sputum from all patients with upcoming appointments who are due for updated cultures and who don't already have that scheduled in person. In addition to making sure that patients are getting this health monitoring equipment, each of those team members has spent countless hours reaching out to patients to encourage them to use the tools we provide, to offer guidance and planned virtual coaching sessions, specifically on how to use the tools and how to use the Zephyr RX Home Spirometer app to schedule or help coordinate in-person sample collection if needed, and to follow up if a patient didn't provide any of this data during a virtual visit. We measure the effectiveness of the strategies we've implemented through regular data tracking, and those data tracking spreadsheets feed into run charts that show our progress over time toward our goals. And we regularly review these run charts as a team. Of note, we've particularly wanted to stay on top of the rates at which patients are providing home health data for their virtual visits, and we review these rates weekly as a team. That data tracking is also used to inform weekly meetings of a smaller QI subcommittee. which I organized as the QI lead, and which also include our nurse manager, our lead RT, and our dietitian. And we use that meeting time to discuss possible causes of missing home health data and come up with mitigation strategies to try. In the first year of the pandemic, we went from having literally 0 virtual clinic visits to holding 93% of our visits virtually. In that time, we were able to provide home health monitoring equipment to nearly every patient household that indicated need. In terms of our yearly visit-related metrics based on CFF recommended guidelines, compared to the previous 12 months, the transition to telehealth during the first 12 months of COVID had only minimal impacts on our yearly visit-related stats. Our metrics show that over 12 months, the overwhelming majority of patients still were able to participate in more than one clinic visit. Also, over 90% still provided at least one throat culture, at least 2 PFTs, and were able to participate in visits that included more than one discipline. We developed a center-specific telehealth satisfaction survey to gauge families' personal experiences with virtual compared to in-person visits, to identify possible areas for improvement, help us determine the best course moving forward, and figure out patient preferences now that in-person scheduling is also an option from a few months ago onward. We sent these out to patients and families via link sent through email and over portal, and we printed out hard copies of them that we mailed out to patient homes along with prepaid return packaging, just for the folks who would prefer pen and paper. And we actually did get a few pen and paper responses back. And even though we didn't get an overwhelming number of responses, the responses we did get didn't suggest any kind of dissatisfaction with virtual visits. In fact, we found that most reported favorable experiences with telehealth, considered virtual visits to provide about the same quality of care as in-person visits, and indicated they'd like for telehealth visits to, at the least, continue to be an option. Our takeaways are that we can say we expect the quality of care we provide won't be significantly affected by keeping the option for virtual visits open, though we may want to encourage in-person visits for those patients who have trouble providing home health monitoring data, and this is something that we've already started working on. We now know we can provide patients with the tools they need to collect CF-related health data from home, and we can provide them with virtual support. But we can't rely on all patients to use these tools and provide updated health information for all of their virtual visits. Collecting this health data in person is still the most reliable method. In terms of co-production, we found that having most of our team collaboration and our team meetings take place virtually actually has helped to facilitate increased engagement with our CFLN and PFPs. It's a lot easier for them to join us when they don't have to come downtown to the Children's Hospital on a weekday morning in order to do so. Also, for upcoming appointments, it's just as easy, if not easier, to virtually reach out to patients to ask about any needs or concerns they have leading up to their visit, and for us to incorporate that feedback into our virtual team meetings, as it would be to do any of that through in-person interaction. And finally, the responses that we got from our telehealth satisfaction survey were overwhelmingly favorable toward telehealth and the continuation of offering telehealth as an option moving forward. So now at the end here, I just want to thank everyone who contributed to all of these evolving and ongoing QI efforts, to our wonderful patients and families, and to all of you for taking the time to listen. And I encourage you to please reach out to me. There's my email address at the bottom if you have any questions or would like any more information about any of this. All right, thanks.
Andrea, thank you very much. That was wonderful. Definitely put in quite a lot of work, and it shows. There are a few questions that are coming in, but we have a few here. Let's see. What is the current ratio of the in-person to virtual clinics that you're doing now?
That's a good question. It's evolving. So just over the past month and a half, we've noticed a huge uptick in the number of patients wanting to schedule in person versus virtual. But prior to that, so we switched back to doing a mix between in person and virtual back in May. So from May to the beginning of September, it was an even ratio, and now it's just kind of, the in-person days have been really piling up. But luckily, we have a very dedicated, on top of things, center director, and he put together the numbers last week so we could see moving forward what it's going to look like. And over the next 3 months, it's almost even again. So it could have just been a fluke, or I'm not sure. But yeah, so I would say that on average, it's evened out.
Do you see that virtual, and how do you think your center and your center director are going to continue to use that? Do you think it'll be, a certain number during the year, or do you think that it'll be more of a patient driven?
We really do value patient input. So like I said in the presentation, we developed a center-specific telehealth satisfaction survey, but we're also trying to get patient input as they're coming into clinic, about whether they want their next visits to be in person or virtual. So we want them to kind of drive how we're moving forward. It's also kind of just based on the schedule too. So if we're just seeing that a lot of patients are scheduling in person, we're going to add more in-person days to our clinic schedule projection, which is something that we started doing after these past couple months. So we were doing every other week was virtual or in person. And when there was a month with, an extra Wednesday or an extra clinic day, then we would make that virtual, and we switched that over so that that's always going to be in person.
Mm-hmm.
So either 3 in-persons and 2 virtuals a month, or 2 and 2. And then, if the schedule keeps piling up for in-person days, then we'll adjust it again.
Mm-hmm.
So we want to see if patients are saying that they want.
It sounds like your structure then is more to do it by clinic session. This is a virtual session versus this is an in-person session, so that your staff isn't split between. Is that what you're saying?
That's how we've been trying to do it, because we've tried to do some hybrid visits, and we still will if need, if the patient's need necessitates doing a hybrid visit, but they're just kind of chaotic.
Mm-hmm.
I don't know if other clinics have experienced a level of chaos with hybrid visits, but more so than what it would be if it was all virtual or all in person. So we've been trying to stick with that.
Yeah. From Slido, how did you handle blood work and OGTTs for your patients?
So our nurse manager has done a lot of outreach to try and get patients either scheduled to come in to the Children's Hospital for just blood work, so just a blood draw.
Mm-hmm.
So they're not technically scheduled for an appointment. They're kind of just coming in for that. They just go to the lab and that's it. Or she's been finding, helping them get in touch with and schedule appointments with other outside labs that they can use for that. So whenever we, if checking the schedule going forward over the next week, over the next couple of weeks, she's scanning to see which patients have, annual labs that are due, so that she can try and reach out to them and be proactive if they're not scheduled for in-person.
Right. And then we were very impressed with the work that you've done with your pre-clinic and your post-clinic. Post-clinic, almost more importantly, because that often is the tie it all together information for families. And I'm interested, and my co-moderator Dina, we were both interested in what you. What platform you use and who actually, you had said that the nurse does the pre-clinic form, and then you all meet together in a post meeting, which I think is very unique to do a post meeting, and then to take another step and push out a post clinic form and a review. And I think that would be something too, that I think the foundation and the CF Educational Committee would be really interested in hearing from you on that. And if you could just explain a little bit more about how that works, and are families receptive to it, and did did that come out of your patient family advisors, or where did that come from?
Well, I will say our patient family advisors were instrumental in providing us feedback when we were developing that form, letting us know what makes sense and what doesn't make sense. And some of the things even that we wanted to include that they were like, we don't need to know this. So, that was very helpful, but it's also been helpful to get more consistent feedback from them too, that, as we've had some challenges with the post-visit summary with getting people to remember to complete their sections and getting it out to patients in time. So we've checked back in with the PFPs during our meetings just to say, we're spending all this time trying to fix the issues that we have with this. Is it worth it? Do you guys read this? Do you appreciate? Right. And they have all said yes, that they do. They like having that extra document at the end of the visit that summarizes what was reviewed. So at least our PFPs really appreciate having it.
And is that uploaded into your MDR, into your medical record, or your portal?
No, it is uploaded into, we share it with them via portal as an attachment. So the patient portal, they get it that way. But, some of our patients prefer email. Our nurse manager, Maridol Lee, who is just amazing. She maintains a record of the patients and their contact preferences. So if it's a patient that wants to be emailed, she sends it to them via email. A lot of times she'll send them portal and email just to cover their bases. So we make sure that patients are able to get those. And we do have a Spanish translated version too that we use.
Oh, wow. Yeah.
So everybody gets a copy of the post-visit stuff.
I do encourage you to share that. We have another question from the Slido from the audience is, what about difficult families who have an issue with adherence? Do you try to get them in more in person than scheduling them virtually? And what does that look like?
So we do. We started a few months ago when we started doing in-person clinic again. Just during our weekly team meetings, we were talking about, well, what about the patients that we really haven't been getting home health data from over the past few months? We should be prioritizing putting them on in-person days. So we got, a list put together of the patients that are the high priority in-person patients, and we've been trying to make a conscious effort to make sure that those patients, when they schedule their next appointments, they're in person. And then recently, I started maintaining a separate tracking spreadsheet that has their individual patients and their rates of providing home health data for their virtual visits over the past year and a half. So if it's a patient that is below 80%, it colors them in orange, and if it's between, I think, like anything below 50 or below 55% or something like that, it colors them in red automatically so that we know those are the patients that haven't been providing home health data.
Right.
And
so they're at a higher risk, so you're flagging them. Yeah.
That we want to make sure when we do see them in clinic and they're scheduling their next visit, we know those are the patients we want to make sure they schedule in person.
Excellent. Wonderful work. We have another comment from the audience is, can you share your post-clinic form? I agree with that. And just reviewing a little bit more, you already answered what platform do you use, and that's either email, whichever way you can get it out to the family, or your portal. And I think you've answered all of them. So thank you. I really appreciate you taking the time to present today, and also just all for your enthusiasm. Love your quality improvement work. You really were a standout in your abstract, and I encourage everybody to take a look at that. So thank you very much.
Thank you. And just a shout out that there are visual depictions of a lot of the different forms and tracking spreadsheets and everything in the poster, which is 119.
Wonderful.
So I'm happy to share the post-visit summary and anything else you see in that poster that you want to use.
Okay. And yeah, I do encourage you to reach out to the foundation with the educational tools that you've developed. So thank you. or the clinic form. Thank you. All right. Our next speaker is Dr. Ahmed Euler. Ahmed is I'm fortunate to work closely with. And Ahmed Euler is a medicine and pediatric trained pulmonologist and director of the adult cystic fibrosis program at the combined Boston Children's Hospital and Brigham and Women's Hospital Cystic Fibrosis Center. His presentation today is physically distant but virtually together. CF community-based webcast during the COVID-19 pandemic. Thank you very much, Dr. Euler.
All right, third time's a charm because I keep going over in my minutes. My name is Ahmed Euler. I'm a MedPeds trained pulmonologist and director of the adult CF program here at the combined Boston Children's Hospital and Brigham and Women's Hospital CF Center. I'd like to thank Dina Kemple and Kate Barnaco for the invitation to speak with you today, as well as the NACFC conference organizers. I don't have any disclosures for this talk. As you know, the COVID-19 pandemic raised great concern, and understandably so, in the CF community, with news, media, and social media not to be trusted, leaving the CF teams in a position to provide trustworthy guidance to their CF communities. Thus, our entire multidisciplinary team joined together in collaboration with our CF community to help each other through the dark days of the pandemic. Just for some background, on January 30th, WHO declared a public health crisis. We had our first case confirmed February 2nd here in Massachusetts. On March 6th, with a Biogen conference that has become well known, 3 positive cases were detected, and then that's when things really spread here in Boston and Massachusetts. The St. Patrick's Day parade was canceled on March 9th ahead of March 17th, and Harvard moved its courses online. Thus, things obviously were getting serious. And on March 10th, Governor Charlie Baker declared a state of emergency. So from March 10th to March 12th, that takes us to the first of our weekly webcasts. We didn't really have much of a plan. We just decided to open it up, and we found 180 people joining us that day, and we've had really high levels of participation ever since. On June 12th, we went from weekly to bi-weekly webcasts and started inviting more outside speakers, as many of us had already spoken so often. And then the numbers began to dip. So we really focused on educating our patients and our CF community on other topics, including talking about what was happening in our communities with the election and social justice and everything else that goes with that. And then there was a lot of CF focused talks. And on December 3rd, we were grateful to have Mike Boyle join us, and also people like Paul Quinton, an incredible community member with CF and a scientist who really moved CF and our knowledge of CF forward, along with Bijal Trivedi, who wrote The Breath from Salt's incredible history of CF. And then also Siri Vaith, our executive president from CFRI. And then in March, as we started to look at monthly webcasts interspersed with every other week web chats where a small community got together, we were able to have Amy Poehler join us for our webcast. And we've been trying to book other celebrities ever since, but we're really grateful for her lifting our spirits during that very difficult time. So what was our formula? Our formula was very Wayne's World. It was like we're in the basements of each other's homes and sharing things that really were unplanned and non-scripted. And so, but we had a lot of fun as we were doing that, playing games. And we're going to show a video that really gives you the full story. But as we continue, I asked the community to share one word that describes their experience, and they came with informative and informed, but community, comfort, fun, relieving stress, uplifting, and exactly what we wanted to achieve. And then we would start with a video. This is how our webcast started. We'd start with a video of a car driving through Boston, since so many of us didn't actually get out of our homes. And so we'd start with little messages. We'd always say hello to Derek, who in his wonderful Boston accent would say, "Hey, Dr. Euler, how you doing?" And then he would say, "No, sir." And it was really, just a way to get started and get the community laughing and, really ready to be together and learn. We would first provide an agenda, and this is an agenda from our last webcast just a couple weeks ago. We celebrated our 10 runners running the Boston Marathon, people with CF running the Boston Marathon. We had lucky enough to have Gunnar Esiason come on, as well as one of our infectious disease specialists and virologists here at our hospital. We'd always have mental health with meditation and music, and of course, question and answer period, which really lasted a long time. This is our adult CF provider family welcoming the CF community, and we always shared this picture and evolving pictures of our group. We started with an inspirational quote, this one from James Baldwin, a civil rights leader and novelist, who said, "Not everything that is faced can be changed, but nothing can be changed until it's faced." And something that really rings true with our experience with the pandemic and having CF. And we also shared many other things happening in our community, including, recognizing people who died, that week or the week before. I'm talking about celebrities like Alex Trebek and others. We had public service announcements. Our teams of NPs, admins, QI specialists, and other folks our social workers, everybody was available to answer questions and volunteer their time. And here we wanted to talk about troubleshooting our new spirometers. We also tried to make coming into clinic a little bit less stressful. And this just does, I'm going to show you the first part of some video that really tried to make our patients feel more comfortable coming to clinic. So that video made people more comfortable. We shared pictures. Here's a picture of Mike showing his vaccine card, but we shared birthdays and births and weddings. Here we celebrated community members like Michael Hilly, who got a grant to create a webcast called But You Look Healthy. We then went into data sharing, and we shared wastewater, COVID-19 or SARS-CoV-2 cases in Massachusetts, which was really the canary in the coal mine of cases going up and hospitalizations going up in Massachusetts. We shared that data both nationwide and locally, and then we shared our vaccine allocation numbers. We also are thankful to the CF Foundation and Paulo Lomas for sharing COVID-19 updates with us, which was really informative for our CF community. And we also shared the updates from our European CF Society patient registry as well. And of course, I talked about our guests, and this is one of our guest speakers being introduced, but also many other guests that joined us, from infectious disease specialists to sleep physicians to many others. We had a mental health corner every time, and we talked about things like managing change during the pandemic, and change was a big part of that. And how do we adapt to that as the new normal was always changing? So I'm grateful to our social workers and psychologists who really focused on maintaining good mental health and self-care. Then we had a question and answer time, and also the question and answers were always really quite incredibly sophisticated, and thus we had to keep up with the COVID science just to keep up with the incredible questions and knowledge that already existed in our community. And then we would have meditation and music. But I really want to share a video that we created together with members of our CF community. And I'd really like to thank Andrea Becker and her colleagues, Amy and Ellen, along with one of our other CF community members, Patrick Nash. This was a collaborative effort that really hopefully gives you a flavor of what the webcasts were really like. I'm dialing in from my bunker here at the hospital. Purposefully, this isn't like a big scientific talk. We want to make sure that we're answering your questions and just be there for you.
In March 2020, our lives changed.
China has identified the cause of the mysterious new virus.
Coronavirus.
We could see it was going to be hard, and perhaps harder on us than most. But we had been through hard before. We knew how to do hard. We knew we needed facts. We needed science. We needed guidance. We needed to count on our own resilience. But what we didn't know is how much we needed each other. Our team at Boston Children's Hospital and Brigham and Women's Hospital started a webcast to gather the CF community and disseminate critical information from reliable sources in a world that was filled with anything but. We talked about the curve. We learned how to continue our care. Remember when everything wasn't virtual? And we talked about our mental health and how to protect it. We were filled with a lot of questions.
You know, we're a community. And don't forget that we're all in this together.
We learned about the isolation to come. We worried about our jobs. And we wondered if that curve was ever going to flatten. As the weeks passed, the pandemic raged on, and so did our webcast. More than half of the 350 patients in the clinic were tuning in and contributing. It was clear mental health was going to be a big part of staying safe and sane. Information is powerful, and the team offered as much as there was to share.
I have to say that John and myself and Simone here tonight, and Isabel and Lindsay and Kelly and Lauren and everyone else who has joined us from the LCF program, we're just really honored to take care of you. We know that this is a really stressful time, so we hope that we can take some of that stress off of you.
But we also got strength from each other. We shared how we were turning our spaces into sanctuaries, how we were focusing on our art and our passion. Our birthdays looked different, but we almost appreciated them more. We shared how we were dressing up for working from home, writing books, painting, making furniture, fixing up motorcycles, running marathons, climbing mountains, and puzzling. We gave thanks to the essential workers who were still out there. And of course we wondered, could you get COVID through farts? Our doctors shared their expertise, their analysis, and their time, but also their homes, lives, dogs, odd collections and hobbies, and that maybe they weren't technological geniuses.
I don't know what's wrong with my camera. What happened to the slides?
Our feeling that we were out of control began to shrink just a little bit. The webcast created space for us to talk about the connections between us in a country that was growing more disconnected every day. We talked about health equity, intersectionality, and our identities. We even went to the beach together, or at least did a guided meditation to beach sounds.
Simply be here now with your breath.
And we danced. We went from being providers and patients to being friends and colleagues. We learned how to keep ourselves healthy when we couldn't go into the hospital. We held our precious collective breath while learning about several likely vaccines. And we bravely treaded into the uncomfortable topic of vaccine allocation. We kept heading toward our COVID PhDs as we heard about mRNA, adenoviral-based vaccines, standard protein-based vaccines, emergency use authorization, and the many plans for equitable allocation. We learned about wastewater analysis, antibodies, remdesivir, hydroxychloroquine, and other treatments under consideration for COVID. As the elections approached, we talked about how to vote safely. We celebrated Halloween together. We talked about the fly on Mike Pence and losing RBG, Eddie Van Halen, and Alex Trebek.
What goes in your nebulizer?
What is hypertonic saline?
Got it.
And of course, we talked about The Mandalorian.
Everyone loves Baby Yoda. Yeah, The Mandalorian's great. Can't wait for the next season.
Together, we came up with creative ways to gather with loved ones over the holidays remotely. We are invited to send in our pandemic stories for the CF COVID Stories project. As the surge surged, we could see the fatigue setting in for our doctors and each other.
Wow, I did let this. Oh wow, I can't believe it's 8. I told our team that we were gonna end early, and I did it again.
But we were also turning a corner into a new frontier as we cheered the first healthcare providers getting their vaccines. And we wondered together how and when we were going to get them too.
As far as the hesitation, whether or not it would be safe for me, I knew that it would, just because this is what we've been waiting for.
Our team did an incredible job of teaching us some complicated science because we wanted more than the simple answers.
I can't wait to hand out shots.
When the time came, we proudly shared our vaccine photos. Those of us who had had transplants found common ground where we could discuss our lack of antibody response. We continued to do meditation and music therapy and rally around each other. As cases came down in the spring, we still wanted to come together and share. Our team continued to provide information, guidance, and content that kept answering our ever-changing needs. We hit our one-year milestone and just kept going, feeling more confident about access to care and medication, more resilient and capable of adapting to our new normal. We felt connected and we felt strong. In a year where medicine had to be transformed overnight, our team had transformed how they delivered care to an at-risk community 1 hour at a time. During the summer of 2021, many of us continued to meet in an informal chat hosted by the team. Now, with fall upon us, the webcasts are formally beginning again. We still don't have all the answers, but we are intact. We see tomorrow, and we have each other.
You're welcome to stay if you want to watch the rest of our podcast.
I might get some ideas for my patients. I'll turn off my camera and just sort of like stalk you guys.
So I have to make sure we end on time. I just want to congratulate our 10 runners with CF completing the 125th Boston Marathon. They're amazing, along with our adult team who also ran with them, 4 of us. And so thank you. I look forward to your questions.
Wow, that was amazing, Ahmed. Quite a story. And we appreciate all of your energy and your effort and your ability to pull teams together. I have a few questions for you that are in the Slido that I'll start with. What do you think was your biggest challenge around doing the webcast, and how could other centers do something similar?
First of all, the video, I don't know if it was the same for others, but the sound was coming in and out, and we're going to post a link that's actually not open yet because we just got everyone to sign releases. So hopefully that'll be available at some points in the next day for you to look at it in a more smooth version, and our also COVID Stories project. I think the biggest thing right now is like, how do we stop them? I don't know how to because we still have a core group who enjoy coming. We have anywhere about, regular group is about 60 to 70 people, as high as 180. And then there's this other 30 to 40, and I feel like they just want to keep going. Right. And so it's just a time. It is a big time commitment, and I'm so grateful for our team. I know my voice was in there more than I would want it to be. I mean, this was, our whole team's voice are on the, I'm just the host, but everybody has been presenting, and so they're there. Our team is there at night. Now it's every 4 weeks for our formal webcast, and then we have like a informal web chat where everyone, all the our community members can just talk with each other and really get to know each other more informally. But I think there's just time is the biggest issue.
and the time worthwhile. It's really quite amazing what you've accomplished in the last year and a half, and so many patients appreciate and feel supported through your generosity of your time and your devotion to the community. There are a few questions that are coming up. How do you feel these webcasts benefited patients during COVID? And do you feel staff also benefited while working remotely?
I think that absolutely staff benefited. So I'll just say that right up front because I was thinking that before. And I know our community members have benefited because they keep telling us, and they're so gracious, with their well wishes, and they know that this is, something that we're able to find the time to bring, all the team members working together. So they're so grateful, and they participate. Our speakers, some of the voices you heard are actually voices of our CF community members sharing their expertise. They've taught us about resilience and, just about how to use mental health and, just do meditation, along with our other team members. But it has really been their commitment as well that keeps us going.
How did you how did you choose your speakers and get them to commit to these webcasts? And were they thoughts that your team thought of, or were they patient driven, or did you kind of all sit there in your webcast and say, so who do we want now? But they must have been both motivational as well as medical and science as well. So how did you decide that?
Yeah, so we had a webcast committee team that met, but we would always send surveys, and we would also ask, community members, what did they want to hear about? So they would tell us, we want to hear from an epidemiologist or a virologist. I mean, they were so thirsty and continue to be so thirsty for direct, knowledge from the scientists themselves. We've reached out to Anthony Fauci and Francis Collins. They have turned us down, but we keep trying. I think that we're fortunate to have incredible people in our community, and we've been fortunate enough to be persistent and ask people. I mean, I think that really people have all been very agreeable, just asking, just reaching out. I mean, there wasn't much, there was no monetary gain. We didn't, give anybody any, any money or funding to join us. So it was really people, I think, wanted to just help and be a part of something, and the webcast appealed to them.
And maybe too, the webcast for the help support them to be able to share their knowledge and to be able to help families and patients that otherwise weren't hearing from them. But I would think that the speakers themselves enjoyed being with your staff and with your patients.
Yeah, a lot of the speakers, would speak. We had speakers really speak for 12, 15 minutes, but then they would stay on and just listen in. So I thought that was kind of neat. I mean, some would have to go, but especially having Paul Quinton and Bijal Trivedi really co-present the book and the history that he was a big part of. That was one of the most enjoyable sessions that we've had. And of course, Mike Boyle coming on was quite amazing as well. That was a big hit with the community members.
I think after doing this, you're going to have more people who are going to want to join outside of the Boston area.
We've considered that. This has been really a homegrown show, and as we do make a lot of mistakes and we have a lot of fun, but it's it has been exclusively for our community, and we'll have to think about if we want to open it up for more people. There is a link, I think that Shauna, maybe you were going to post it, that you can go to the www.the.cf COVID Stories Project. I just want to say that Andrea Becker and her team, they were really responsible for that video, putting it together. I think I mentioned that on there, but so grateful to her and her skill, her voice was just incredible in that video, and really captured sort of our, what we've done, the music, the dancing, the games that we played. I mean, we have had a lot of fun and continue to have fun. and the science. I mean, it's all about the science. Everybody is really hungry for knowledge.
Yeah, I think so. And the way that you presented and being inclusive with your patients and really bringing them into your home or your office or your cave there is remarkable. And I think it puts a whole nother light on what educational days can be. They don't have to be so regimental. You can have some fun with them, and families or patients can really participate. So we really appreciate all of the work that you've done.
No, thank you, Kate. You're a big part of our center. I appreciate that.
I think that that's all the time we have right now. I'm sorry, there is one more question for Ahmed. Have there been specific actions from your team that you feel most encourage community members to participate in these webinars? And particularly now that many folks are dealing with so much Zoom fatigue, are you finding that it's decreasing, or are you finding, what are your thoughts on that?
Yeah, and there's certainly Zoom fatigue. We are not having as large numbers in the more recent weeks. I mean, and there's other reasons for that. I think it's picking up again. I would say sharing our personal stories. I think that people in our community really like to see our kids and see like our horrible background and our, you know, our homes that are disasters and various other, you know, sort of our frailties alongside theirs. And I think that that allows them to also share and open up.
Bring humanity into it.
Yeah.
Yeah, definitely. We're running out of time. I do want to thank everybody for participating in this workshop. You've all done such a tremendous amount of work, and we appreciate all of you coming. I love from Ahmed that, you know, webcasts and education where we can be fun and supportive to all of our families. This completes our workshop for today. And on behalf of our speakers and co-moderator, Dina Kemp, we want to thank you for taking the time to be here with us. If you have any further comments or questions, don't hesitate to reach out to our speakers for follow-up, and enjoy the rest of the conference. It really looks like it's been a wonderful time. Thank you all.
Thank you.